Thank you again, Siva, and good afternoon, colleague. Approaching the PDA from the head and neck vessel, when and how? Well, perhaps we are talking about two different anatomy, try to match. The first one is the PDA morphology that has been debated, has been highlighted just now. The second thing is that the neck vessel anatomy that potentially not been looked at if we would like to approach either from carotid or axillary approach. Generally, MSCT very useful tool to delineate not only the PDA morphology but also the neck vessels anatomy. Generally, the TOF PA or PAVSD has rather complex ductal anatomy, either this type 2 or type 3, more tortuous than the other kind of PDA in single ventricle like tricuspid atresia, and of which I think conventional transvenous approach from the femoral venous or femoral artery is technically difficult and carries certain risk. Generally speaking, if the arch is to the left, if we want to attempt through the axilla, it should be the contralateral of the arch, like to the right, or the right carotid. And if the arch is to the right, probably the left axillary artery approach is the general rule, but not always true. For example, this is one of the patients that has duct-dependent pulmonary circulation that's attempted to implant for PDA stenting. This is the anatomy. This is left arch with aberrant right subclavian from descending aorta. There's a lot of some collateral, probably a sequestrated lung as receiving supply from one of the neck vessels. So you have to look carefully. The PDA anatomy is something quite, to say, straightforward for stenting. The only approach that we need to decide is either from the carotid, right carotid, left axillary, or I think all these neck vessels opening is perhaps well opposed, directly opposed to the opening of the ductus, so we can always choose either one is comfortable to the operator. We look at the back. This is another important information in complex anatomy. This is from the back image of this patient. This is the right subclavian artery arising from descending aorta. This is the one that's the collateral that's supplying right upper lobe. This is the left subclavian, left carotid, right carotid, and perhaps the ductal opening is practically at the belly, below this, and very, as I mentioned just now, either neck vessel it can be used. However, in rare occasions, you don't have the image over here. The ductal opening not necessarily below; it can be on the side, of which it make identification of that, take off the side of the PDA, either on the left or the right inferior, then it's very relevant to choose which neck vessel is suitable for cannulation and stent implantation. In when and how, I think using the neck vessels, commonly as mentioned just now, is the pulmonary atresia, VSD or TOF pulmonary atresia, of which the ductal morphology, ductal anatomy is under the belly of this arch. This is quite common. I do not want to share with detail, but share with this image of which the approach left arch from the right, yeah, and sometimes it can go from transvenous route, but potentially cause some technical issue with regard to heart block, arrhythmias, and sometimes stent migration during stent implantations. Can go through the left axillary approach like this one, or even carotid approach. I don't have much experience of trans carotid approach. I prefer axillary approach in almost all most of the cases, but otherwise carotid can be considered, because especially those are young, small patients where the carotid seem to be get a bigger caliber as compared to axillary artery, a bit more invasive, but usually as a help, require help by our surgeons. For axillary approach landmark, I think we need to know a bit on this. May do direct puncture, usually able to, but not always. But I normally require some kind of wire guided with or without cannulating the femoral artery. Sometimes you just put small femoral artery cannulation and put a coronary wire up over here as a guide, and practically give us a quick puncture using this, and then to make sure blood coming out and go through this process of inserting 4 French short delivery shields across here, and over the coronary wire put a juxin right catheter, and by having 2 balls at the end, you can use as a contrast injection to delineate the position and the orientations of the PDA. And then subsequent to that, I think is pretty obvious. This is the same image, actually, the same case I showed to you, the abnormal vessel that's applying right upper lobe secreted lung with aberrant right subclavian artery rising from the descending aorta, successfully stented. What about the rotational angiography? Whether that's able to give you a better idea, but I don't think this is. I prefer pre-procedure delineation and anatomy, so that we can perhaps directly puncture which next vessel for the root. But the other route that we normally use is, this is the one of which there's some complication of stent. This is a TORC PA with vertical PDA. The stent was delivered through the transvenous route, but if you watch carefully, this is not uncommon. If you do not careful, when the inflating the balloon, the stent tend to move forward, because when you inflate the wire, the balloon tend to straighten up, and the shortest way, easiest way is making forward. So it means part of the proximal end, the ductus, may not be covered. So then, of course, try to rewire through the conventional way is difficult, so we have to go through the either left or right axillary approach or carotid. In this case, the right axillary approach is easily cross the stent that migrated, and additional stent was deployed proximal to the first one to give a good result. The second rescue procedure is when the first there's some complication, though it's rare. This is acute thrombosis or gelling, the contralateral PA. This is the obvious gelling, or we can't see the left pulmonary artery flow. Then we need to have some access from the right axillary approach to rewire, cross through the strut of the stent, and balloon dilate, then followed by stent reimplantation to the left to give a better result. Okay. This is another condition of which the neck vessels approach is important. This is very unfortunate. The post-stented PDA being neglected because of some reason, probably socio-economic reason. They only came back a year later, where the left pulmonary artery is jailed. Then we have to rescue this by recrossing through the left axillary and able to open up, and this is the results 3 months later, prior to the total corrections, surgical total correction. The last that I would like to share with you is those case where the condition where the left primary artery or right primary artery is disconnected to the main primary artery. In this case, it's tough with disconnected left primary artery. A 2-month-old patient is more or less asymptomatic, but this is practically trying to salvage the left. We have to go through axillary approach, opening up the almost completely block of PDA, then put a stent. This is before, this is after the stent, to show that there is a left primary artery able to be recruited prior to total corrections. So in summary, approaching PDA via neck vessels, I prefer axillary artery approach.